Good afternoon, everyone. We should be starting here in just a few moments. If you are a committee member who's on the phone, if you would please unmute and let us know that you are here.
This is Dr. Robert Baird.
Good afternoon. So, Michael, we do not yet have a quorum, so I don't know if you want to kick it off and do minutes later, but I will let you know when we've got a quorum, but I know other people are still joining.
Okay, thank you, Sharon. Good afternoon, everyone. We would like to welcome you to our March Medical Care Advisory Committee meeting today. We have a busy agenda to get through, and we'll wait to adopt the minutes once we have a quorum. So first item on our agenda is to do an overview and purpose and role of the MAC. So I was going to do a quick overview on that. So Sharon, if I can present, I'll just take over for you. Here we go. All right, so we'll start on this because they're incorporated in our bylaws, but I thought it would be helpful just so everyone knows where these bylaws are located on the MAC webpage. So once you go to the MAC webpage, on the third item here on the quick links is where we have the bylaws. And once you get into the bylaws and scroll down a little bit, that's where we have the purposes and functions of the MAC listed as part of our bylaws. But as a general point of background, it's important for people to know that the MAC is required by federal regulation for the state Medicaid program to receive federal Medicaid funds as part of the program. So it is required by the federal government, and we're fulfilling an obligation that is laid out in federal requirements. As we look at the top of these, let's go back. So we look at the purposes, formulate and recommend policies, analyze programs, and review services provided recipients under the Medicaid program. 2, to improve and oversee the quality and quantity of the services provided under Medicaid. 3rd is to provide a two-way channel of communication among individuals, organizations, and institutions in the state that, with the division, provide and/or pay for medical care and services. Facilitate the democratic process, create public understanding, and ensure that state services meet the needs of the people served at a reasonable cost to the taxpayer, and to plan for future medical assistance programs or discontinuance of existing programs when appropriate. And then just moving down the page a little bit more under Article 5, Function, Section 2, if we look at the specific functions of the MAC, interpret community opinions, attitudes, and needs to the department as requested by the department to other agencies that contract with the department, to provide services in connection with administering the program, study programs and services, analyze problems, provide information and interpretation of programs and budget requests, and review and recommend changes in programs. So I just think it's helpful each year to take a few minutes and review the big picture on what the MAC is supposed to accomplish. And for those of us on the MAC, what our designated purpose and functions are as we advise the department on policy, budget, interpreting community feedback, and look to generally improve the program and advise some perspective. So with that, I'll just ask if there are any questions about that from any of the committee members or comments. Okay. All right. Then next we have Stephanie Saperstein to give us a little overview of open and public meetings, which we on the MAC are subject to under state law. So Stephanie, if we can have you go through that for us.
Okay, thanks, Mike. It's good to see all of you. My yearly visit to the MAC. All of you should have received an Open and Public Meetings Act handout. It's a summary of the key provisions that are in the Act. It's up on the screen right now. One of the things I want to clarify is this is not legal advice. This is simply a summary, and is not meant to be legal advice. It's for the purposes of training. Any mistakes that may be in it are all mine and not the department's or anyone else's. So if you see a problem, feel free to contact me. Under Utah Code 52-4-104, it's required that members of the MAC be trained, any public body, but of this MAC, be trained annually on the requirements of the Open and Public Meetings Act. It has been determined that this MAC is a public body as defined by the Act and is therefore subject to the Open and Public Meetings Act. The stated goal of the Open and Public Meeting Act is to ensure that the state, its agencies, and its political subdivisions take their actions openly and conduct their deliberations only. So that's why we do this in the open. We also track all of the changes to the Open Meetings Act in the general legislative session every year. There was, again, changes made to this act under House Bill 36, Substitute 3. And one of the things that's important that I want to emphasize up is what is a meeting. The legislature redefined what a meeting is, and I put it up in the top left-hand corner of your of the handout, and it's in bolded. And so a meeting, a quorum of the committee may not meet to predetermine an action to gather okay, I'm going to read directly. A quorum may not act outside a meeting to predetermine an action to be taken by the public body at a meeting on a relevant matter. That means you can't pre-meet ahead of time, make a decision on what you're going to decide or talk about in the meeting. So everything has to be done open and publicly and on the record. This does not apply to an individual member who's acting as part of the body, but it's not a public body. So if it's just one of you and it's just two of you having a discussion, you're not going to be violating the law, but you can't meet together to pre-plan what you're going to do in the meeting. The legislature redefined what a meeting is. So in this year's legislative, there were some questions about what's a meeting, what's a public body, and the forms of electronic meetings that can be done. The House Bill 336 Substitute 3 clarified a lot of these questions that we've been having over the year, either through definitions or through other requirements. And those clarifications and amendments that were made in 2024 are in the highlighted blue box on the top left hand of the handout on the first page. So we've talked about when you can meet and when you can't as a quorum. Please be careful. We don't want anybody to get in trouble or be accused of meeting outside of the public meeting that is scheduled. If you have a public body is then required before you have your open meeting to provide a public notice of your meeting at least 24 hours before the meeting is to take place. The notice has to include the date, time, and place, and include an agenda that specifies the topics you'll consider. The same notice must be posted on the Utah Public Notice website, and it should include and at the location of the meeting and provided to a newspaper or local media correspondent. The department provides administrative support to the MAC, and it ensures that all of these technical requirements in statute are met with every time you meet. Let's see. You may, during your open meeting, discuss an item that's not on your agenda, but you may not take a final action on the item at the meeting if it's not on the published agenda. You can, as I talked earlier, there have been some clarifications on electronic meetings in the statute this past legislative session. Now, as part of the clarifications is the committee may conduct a meeting electronically, that some or all members of the public body attend through electronic video, audio, or both video and audio connection. So they've clarified what that means and when you're allowed to do it. A member of the public body who participates in the meeting via electronic means shall be counted as present at the meeting for a quorum, participation, and voting requirements. What this means is your members can appear electronically by statute. As required by the Act, you also must follow an administrative rule that the department has made, and that rule is R380-42, which governs how to conduct an open meeting electronically. This rule will need to be updated based upon the changes that were made in the 2024 legislative session. And at some point, we will notify the MAC when those are updated so the MAC can share any new requirements to this committee. So that, the department can share any new requirements with the committee. If you meet electronically, which you are doing now, the designated anchor location for this meeting is at the Cannon Health Building at 288 North, 1460 West. A quorum of your members is not required to be present at the anchor location. And in fact, new changes in the statute clarify that all MAC members can attend the meeting remotely. And that complies with statute. If all MAC members plan on attending the meeting remotely through electronic video, audio, or both, then they can do that unless you receive a written request at least 12 hours before the scheduled meeting time to provide an anchor location for members of the public to attend in person the open portions of the meeting. That means that you do not have to, when this new statute goes into place, you do not have to provide the anchor location for people to attend unless there's been a request 12 hours before the electronic meeting, and it's posted in your notice, is scheduled. We will again update the rule to incorporate that new change that's allowed by statute. The rule also allows the person presiding the MAC the meeting to restrict the number of connections for members of the public body that are allowed for an electronic meeting based upon available equipment capability. I don't know if that's happened or if it's ever happened in this particular meeting, but they are allowed to do that under rule. Minutes and recording. This meeting must be kept. There must be written minutes and recordings of this meeting unless the meeting is a site visit or a traveling tour where no vote or action is taken. The minutes must include the date, time, place, the names of the members present and absent, and the substance of the matters considered, and a record of each vote. If this committee takes comments from the public during the meeting who are not members of the MAC, the commenter must first be recognized by the presiding officer. then the commenter's name and the substance of their comments in brief must be included in the meeting minutes. So anybody who is listening to me who is not a member, please be aware that if you make a comment by law, that your name and the substance of your comment will be included in the meeting minutes. Pending minutes of this meeting must be made available within 30 days after holding the meeting. Approved minutes must be posted on the state website within 3 business days of approval. The recording of this open portion of the meeting must also be posted on the public notice website within 3 business days after the meeting. You must take committee members, you must take a draft of your minutes available to the you must make a draft of your minutes available to the public within those 30 days. Please don't forget that's a violation of the Open Meetings Act if those are not posted timely. Along with your approved meetings, you must also post any public materials drafted at the meeting or provided at the meeting within 3 days after their approval. So this handout will be part of the material that will be posted from the meeting minutes. So you can close an open meeting under certain circumstances. There aren't a lot of circumstances or that the MAC considers that would require or be allowed under the Open Meetings Act, but I'll go through them just just to make sure that you are aware for educational purposes. You may close a meeting by a 2/3 vote of the quorum present for discussion on the following: a person's character, competence, or health, pending or imminent litigation, matters related to the sale or acquisition of real property, the deployment of security personnel, devices, or systems, deliberation and decision-making involving the procurement process. So as you can understand, there's very few times, if ever, when the MAC would need to close a meeting based upon this list. However, if you do vote to close a meeting, you must announce and record in your minutes the reasons for closing the meeting. You may not take a vote in a closed meeting except to vote to end the closed portion and return to an open meeting. You also, and this is going to be rare as well, conduct an emergency meeting as allowed under statute. You may hold it. What that means is that an emergency meeting is a meeting that is conducted that does not require 24-hour notice, and it can be done if an unforeseen circumstance arises that requires you to consider matters of an emergency or urgent nature. However, you must first attempt to notify all MAC members and seek approval of a majority of the MAC members before holding that emergency meeting. Any questions so far? We usually go through this pretty fast or pretty technical in nature, and we rely heavily on the support that the department provides, the administrative support that the department provides. Any questions? Okay, to go through it so we can comply with statute, I'll go through very quickly again the box on the top left of the top right of the first page that are changes made to the Open Meetings Act through HB 36 in the 2024 legislative session. HB 36 modifies the definition of anchor location, electronic meeting, and quorum. It enacts a definition for relevant matter. It adjusts provisions relating to the transmissions of electronic messages, anchor location for an electronic meeting, and recording of a vote at an electronic meeting. And then it modifies language relating to posting a written notice of an electronic meeting. Oh, sorry. It repeals the language relating to posting a written notice of an electronic meeting. Again, as a quick explanation, some of these are technical changes. Some of these are clarifying some language that was already in the statute, but it was focused mostly on electronic meetings, when you can have them, when you can't, when you need to post. And then it also repeals or replaces language relating to chancellor social meetings. Like I said, very clear now when you can act or cannot act as a quorum outside of a public meeting. And those are the changes to the 2024 in the 2024 legislative session. Any questions? Okay, I'll turn it back over to Michael then.
Okay, thank you, Stephanie. That's a lot of good information. We appreciate all of that background you've provided, and we will try and make sure we're complying on an ongoing basis going forward. But I think specifically a nice relief to know we can continue to meet electronically without any problems there. Okay, next we're gonna, well, let me pause and just see. Sharon, do we have a quorum yet?
Yes, yes, we do.
All right, very good. Then let's see if we can get our meeting minutes adopted, as is one of our requirements of the Open and Public Meetings Act. So did anyone have any changes or ready to make a motion to approve? Davis, go ahead.
I'm sorry. I was just going to say I'll make a motion to approve, but I don't have any changes that need to be made.
Okay, that's great. Motion's on the table. Do we have a second?
This is Lisa. I'll second.
Okay, thank you, Lisa. All right, we'll vote by silence. So unless anyone opposes, we'll just assume that they are unanimously approved, unless you don't approve, and then please let us know right now. Okay, thank you. We'll consider the meeting minutes approved. Thank you, Sharon, for gathering the quorum status. All right, next we are going to move to Jennifer to go through a summary of legislative bills and actions from this past legislative session. Lots of activity, so we'll look forward to this report.
Yep, thank you, Michael. Hello, everyone. Eric is tagged to follow me with budget impacts, and we have elected to kind of co-present our items so that we are kind of working in the same document and have the ability to just go through this grouping together. So as I bring up the presentation that we have for you here, we look forward to going through our items with you. As Michael mentioned, it was a busy year. Lots of things we're looking forward to. And so we'll cover these here. If you have questions throughout the presentation, feel free to interrupt throughout, and we're happy to answer your questions. Eric, I'd like to just begin with you first, if you want to go through the items that came out of the Executive Appropriations Committee and some of the funding changes.
Certainly. So first off, we have Medicaid consensus. And for those of you who may not be aware, it's a process where the division meets with the governor's office and the legislative fiscal analyst, and we make our projections for what costs are going to be for the current year. So in this case, state fiscal year 2024, and then also for the out year or state fiscal year 2025. And as you can see, here are the appropriations we received as a result of the consensus process. Now, one thing to note, on the restricted funds so the first bank there is actually 2024, and you can see there's a large amount of restricted funds appropriated to the division. What that is, that's made up of three main components. The first one is they give us what we call a buffer in case we have overruns in the Medicaid program. But the remainder of that is made up of two things. Number one, we have some concerns as of late of new drugs that are coming to market that are very, very expensive. We call them ultra high cost drugs, where these treatments are anywhere from $500,000 to several $1 million per treatment. And so we asked for additional buffer for those because it's kind of an unknown. We don't know how many of those we're going to receive. And so we wanted extra funding. It's not funding we will use. We will only use it if those services actually come to fruition and we actually do incur costs. The last remaining piece was due to the implementation of the PRISM system. We were aware of several providers who were slow to bill in state fiscal year 2023 due to, well, I wouldn't say the providers were slow to bill. We were slow to get payment out to providers based on the PRISM system. And so we wanted to have additional buffer built in to cover those costs that normally would have been incurred in state fiscal year 2023, but will actually be incurred in state fiscal year 2024. So that kind of covers that first part. And then the second part, you'll notice for 2025, you'll see there are both one-time and ongoing reductions and appropriations. The majority of it is a reduction, and that is largely due to Medicaid unwinding and having a considerably smaller population in state fiscal year 2025 on the Medicaid program. So I'll pause for any questions on Medicaid consensus. So that's kind of a lot of information all at once.
Eric, let me just ask a question on how big, I know you had put in place whatever forecast you had for enrollments, and then you mentioned the unwinding. Just it's people coming off the program in larger numbers than had originally been projected as the key driver. Do you have any numbers in terms of the magnitude of the change in like overall enrollment of what you had originally budgeted for and what has been experienced that led to these numbers, just for some perspective for everyone?
Yeah, just for perspective, sure. We had initially budgeted, and the disenrollment has exceeded our expectations from all our initial projections. There's kind of a lot of uncertainty around that because, you know, our rational minds try to wrap around it and think, okay, do we really anticipate that enrollment's going to get this low? And so, you know, Michael, as you're well aware, we do have another shot at consensus in 2025 when we will be meeting again in November. And hopefully by then we have a better feel for what's happening in 2025. We're anticipating that a lot of these people that did disenroll will return to the program. And so these are just based on the numbers we have as of this point in time.
Okay, thank you. But it also took into account what you've experienced in terms of the number disenrolling and then roughly 30% coming back on the program. That was all taken into account in your modeling.
Yes, that is accounted for here. We just anticipate, we you know, again, the rational thought behind it is there's a good possibility that more will come back beyond the 30%.
Okay. Great, thank you.
Okay, Jen, would you mind scrolling down just a little bit? Okay, so the next section, these were cuts that were primarily made in 2024. The first line is kind of a conglomerate of all those items. Now, what these were are we received funding in the 23 session for items that took effect July 1st of 2023. Yes, that's right. 23 session for July 2023. But due to the way that providers bill, there's kind of a lag between when the services start and when we actually received billing. And so the legislative fiscal analyst proposed these cuts during the session where we would reduce the costs for about 1 month on a lot of these services because there would be that lag in billing. And so we as a department agreed with that and thought that was appropriate for them to make those one-time cuts in 2024.
Okay, but that is just to be specific for those watching. That's a line item on its own. You haven't articulated what those are because there were several items that were grouped into that first line.
Correct. And we're happy to do that if there are questions about it. It's they're basically funding items that came from the 2023 session. The next is the emergency only program savings. And this is, as a lot of you are aware, we do cover emergency only services for people who are undocumented. And because we rolled out the state CHIP program that had an overlap of covering some of these children, these are our estimated reductions that would apply to the emergency only program because these children will now be covered on the state CHIP program.
And to be clear, since that came out in discussion in the subcommittee, there's no change to the program. It's just different bucket of funding that's covering it. So people shouldn't anticipate or take away from this meeting there's any programmatic changes at all affecting the emergency only program.
That is correct. Thank you, Michael, for that clarification. Okay, the next two lines are cuts that came from the Executive Appropriations Committee. The first one is they cut state funding for the disproportionate share hospital payments. And the final one is a cut of funding, of state funding for graduate medical education. And those bottom three all apply to state fiscal year 2025, so starting July 1st. The next item we have is the pharmacy dispensing fee. And so we received funding to increase our pharmacy dispensing fee. This is something we're doing on the fee-for-service side. And there was intent language around this that the managed care plans would be able to choose whether or not they wanted to follow suit with what we were doing on the fee-for-service side. So this is the funding we received. Michael, do you have a question?
Yeah, I was just going to comment, even though there was no obligation, that there was sufficient funding to put into the rates for the managed care organizations for them to make that same increase. Is that correct?
No, there was no funding provided for the managed care entities and their rates for this increase.
Okay. All right. Thank you for that clarification.
So, and if I could just comment on that, with regard to the dispensing fee, if there's a specific question as to what we pay today and what the future dispensing fee is. Today, pharmacies in an urban setting are paid $9.99 for a dispensing fee. In a rural setting, it's $10.15. This will update the dispensing fee to a uniform $11.57 per dispensing, regardless of urban or rural setting.
Great. Thanks, Jen. I was actually going to ask you to comment on that, so I'm glad you did. Okay, next up, we have a Medicaid rate increase for nursing homes. We received $1 million general fund, which will match that with federal funds to give a total increase of $2.8 million. So Jen, do you want to scroll down? Okay. The next item we have is coverage for ambulatory medical detox services. As you can see, there's a one-time and an ongoing component based on our estimates of when those services will actually start being billed and the frequency and the volume of those services in the first year. So the ongoing is more representative of what we would expect to see going forward after the services have been in play for an entire year. The one-time offset is to reduce for that kind of startup phase for this coverage. And number 6, we have ground ambulance mileage reimbursement. You can see that that funding comes from restricted funds, which those funds are from the ambulance provider assessment fund, which will be providing the non-federal share, drawing down federal funds to increase ambulance rates, ground ambulance rates by $3.7 million. So any questions on any of those funding items? Andrew.
Eric, I suspect that Jen may cover this in bills, but just in case, could you all talk about what happened with the local mental health authority match, and both what happened with it and what the plan is going forward? Because that all happened at the end of the session, and it was very confusing.
Sure.
And I suspect that it will. I suspect that it also plays into the criminal justice waiver bill as well, and that's why I think Jen may handle that. So
yeah, it is down further in our presentation. So
great.
Yeah, we'll get to it. It's under HB 501, correct,
Yep.
Jen?
Yep.
Yep. So we'll get to that in just a moment, Andrew. Thank you.
Thanks.
Okay, Jen, do you want to start with HB 38?
Certainly. Thank you, Eric. Okay, so diving into bills, first item we'd like to cover is HB 38, the Psychotropic Medication Oversight Pilot Program Amendments. So this bill does 2 important things for children within the foster care system and also those in JJYS. The first piece is the UPOP program, the Utah Psychotropic Oversight Program, was run as a pilot that would have sunset this year. This is a program that provides, is run through the University of Utah Department of Psychiatry and a group of pediatric mental health providers review mental health medications for children in DCFS. They also are now going to review medications for psychotropic medications for children in JJYS as well. They work, this review will then provide recommendations to providers, family members, caregivers, and other care coordinators to improve the prescribing of these medications for children who are high risk. And so this program will not sunset, it will carry forward. It also moves the program. This program has been within the Department of Health, but not run within Medicaid. It does move that program into the Medicaid program as well. And they do great work. We're excited to continue for this program to carry forward. Additionally, there has been a longstanding disparity in the rates between what providers get paid for mental health services delivered to children in DCFS or foster care and those in JJYS. And so this bill adjusts those rates so that there is now parity of those rates. Eric, do you want to cover what the funding on that was?
Sure. So on the program side, we have it set as transfers, which is basically general fund that was appropriated to DCFS, JJYS. And with that, we'll be drawing down the federal funds to pay for the services. And on the administration side is just showing the costs for those administrative activities related to this program. So pretty simple stuff on this one.
Okay, and I think just to highlight, I think the value of this bill is that as we look at children at risk who of course are experiencing and trauma and have already may be predisposed to complex behavioral health conditions at a very young age, this really does build up the level of care and supports that these children are able to receive, and we're really grateful for this bill and the opportunity to improve services here and continue other services. Next is HB 51, Health and Human Services Funding Amendments. And so, Eric, do you want to take this one and describe just briefly the two different accounts and what this bill does to put them together and renaming the other account?
Yes, happy to, Jen. So historically, we had these two accounts. The first one was the Medicaid restricted account, which was made up primarily of any time that money was appropriated to the Medicaid program and was not spent in a fiscal year, it would roll to the Medicaid restricted account. The second account is the Medicaid Growth Reduction and Budget Stabilization account, which came about when the accountable care organizations were created several years ago. And this account was funded and filled with a calculation that we do every year to determine how much savings are attributable to the ACO model. And so what this piece of legislation does is it combines those two accounts into a single account to basically have one place where this I guess you would call non-general fund funding comes into the Medicaid program. So it just kind of centralizes those into a single fund. There also, the next part is with the Medicaid Expansion Fund is being renamed to the Medicaid ACA for the Affordable Care Act Fund. Finally, no, go ahead.
Finish your.
Oh, I was going to say the last part is the bill also directs the legislative fiscal analyst and governor's office to do budget stress tests on the Medicaid program.
Thank you. So my question relates to how the Medicaid restricted account and the growth reduction and budget stabilization account will function in tandem going forward, because the growth reduction and budget stabilization account historically had limitations on how that money would be spent. My read of the bill was those limitations are still in effect. So in a certain way, you kind of still have two accounts within the combined account in terms of how you can use those funds. And could you just kind of speak to how you see that going and how we can, on the public side, maintain the visibility of the amount that's historically been in the Medicaid growth reduction and budget stabilization account?
Sure. No, you're exactly right, Michael. It does have kind of in the bill, it actually limits the use of those funds to certain provisions. And so it's almost like we'll be keeping a separate ledger internally of how much was put in that went in for what historically would have been the growth reduction and budget stabilization account. So that's my thought process, is we'll just keep an internal separate ledger of here are the funds that came in this way, here are the funds that came in that way.
Okay, and then to the point of how is that going to be visible to the public, though? Because right now you can go out on the funds report on the legislative website and see the actual dollar amounts in those funds at the end of fiscal year. So maybe if you can just kind of anticipate that, and if there would maybe be two lines or whatever that looks like, keep us posted on where you end up there.
Sure, it's definitely a discussion we'll have with state finance.
Thanks, Eric. Next item is HB 59, Federal Funds Contingency Planning. So another activity that's really focused on the federal funds that we are using on behalf of supporting not just the Medicaid program, but other government programs as well. And the purpose of this bill was to implement and require that a contingency plan be drafted for any federal funding over $2 million. This does not limit, like I mentioned, to just Medicaid, but government funds or departments that use government federal funding to exceed more than $2 million. Next item, HB 71, Behavioral Health Crisis Response. So this incorporates a new type of transportation whereby the Department of Health and Human Services will reimburse non-emergency secured behavioral health transport providers. This is a provider type we currently do not reimburse for in our state Medicaid program. It's meant to supply an avenue for transporting non-emergent individuals who have behavioral health needs in a secure setting, and it's perhaps not going to utilize the EMS services that are being utilized today. There's also a directive for us to research whether or not this type of provider could qualify for an assessment underneath CMS rules. So we are working with CMS to work through those right now. This is a non-licensed provider. And so asking those questions around licensing and whether or not that licensing provider, non-licensed provider, could qualify for any type of assessment in those transportation, in the transportation rates. HB 139 really extended the sunset on the hospital assessment, hospital assessment revision, extended the Medicaid expansion fund, inpatient hospital assessment, and the Medicaid expansion hospital assessment repeal date. So it extended all of those pieces. Next is HB 392, nursing care facility modifications. So this modified a way that penalties had been assigned to nursing facilities for failure to make a payment on time. So what this did, it removed statutorily prescribed penalties and interest that was imposed on the nursing facilities, and it allowed the division to develop a way to create a penalty for facilities who didn't pay on time without having to go through the same pathway. So there is still a penalty that would be paid, but it's done through a different pathway and not the same route. So less complicated pathway. HB 501. So this one we'll spend a little bit of time talking about health amendments. So the first piece that this bill includes is that it does modify what has been our 1115 justice waiver that was originally framed in 2020, submitted to CMS in 2020, and we've been waiting now for almost 4 years to work with CMS on this justice waiver that was envisioned now 4 years ago. What has happened since that time is that CMS did release guidance for states in April of 2023 that did frame a sort of a model of care for reentry and services that would be incorporated into pre-release care management and the delivery of healthcare services as a person then does move through reentry. And so what the purpose of this bill was to really meet the standards that CMS had outlined in that state Medicaid director letter. So with this, what we see is that we will be able to qualify and, well, first of all, make all Medicaid eligible individuals who are residing in a public jail or prison eligible for Medicaid 90 days pre-release. And at that point, all physical health, behavioral health, and substance use treatment services, there is an outpatient benefit package that is being designed specifically within the carceral setting. That scope of services can be billed to Medicaid during that time frame. Also during this time, there will be case management services that will be in that carceral setting, really looking at the care that's being delivered for that person, looking at the person's needs, and developing a comprehensive care plan that can then be coordinated with the providers care management team that will be supporting that individual in the community setting. So this case manager that we have designed would be a case manager that works inside the carceral setting, and there would be a warm handoff into the community. This waiver also designs a 30-day medication supply to be given to the member upon release. It also requires social screening of the individual so we can identify if that person is at risk for housing instability or homelessness and would qualify for housing-related supports and services. So this justice package for us was something that was in the governor's budget and is a high priority for us. And we're thrilled that it did make it into this bill and that it was successfully made it through session. Go ahead, Stephanie.
Thanks, Jen. When is the waiver? What's the timeline on the waiver? And like whenever it will have, like whenever there will be like a public hearing for the waiver?
Yep, great question. Let me tell you, this is right now one of our top priorities to discuss with CMS. We have been discussing this with CMS over the past year, but because we recently received approval on the waivers we were working on, we have initiated weekly discussions with CMS just like on the heels of this being approved. We had to wait until we knew that it made it through the legislature and met CMS requirements, but our goal is to have a public hearing. And team, I'm backing this up a little more even than what we have noticed. We have this planned out for public hearing as soon as the bill moved into law, but we also are contemplating whether we could hold a public hearing maybe a week or two prior to that. And so I think it's going to be mid to late April. We have it or slated in early May. Right now we have it slated for early May, but I want to talk to the team about moving that to mid to late April. Okay, Stephanie.
Thank you.
Yep, the timeline on this bill, this is a priority bill for this federal administration. They have noted with us that we've been waiting for 4 years. Right now, there are 3 states with approved justice waivers. California was first, Washington, and now Montana. So we are prepared. We have our waiver drafted. We've already submitted our draft waiver to CMS for their review and coaching and feedback before we officially submit that. So we are actively working and engaging with them on this priority policy for us. One element of this bill is that it does require reinvestment of our savings. That is a component of this carceral package that is put together. We'll be teaching you a lot more about that later. But the federal dollars that are invested into the carceral system through this waiver require a reinvestment plan that a state must submit to say, how are you building up a system of care for individuals that are moving through the criminal justice system to improve it? And it actually says those state dollars that are offset by those federal dollars need to be reinvested in services and systems of care. And there's a broad array of things that we can use these dollars for, but it will certainly strengthen this, the supports for these individuals. The other piece that I want to call out that's not right here on the presentation, but I'll add in before we distribute this copy to you, is housing supports. There was an element that tied in housing related services and supports. So our policy that currently exists underneath the 1115 waiver that gives an array of services to help a person navigate housing and work with first and last month's rent and those things. That is going to be extended to our justice involved population up to a year after release. So a person could become eligible upon release or up to 12 months after release. So we'll be submitting our housing amendment along with our justice amendment in the spring, in the next few weeks. This bill also includes another component that I'd like to just share with you that is not on here either. And I'll add this one in too. And so primary care rate increases. Another request that was important to us was an investment in primary care. And as we've looked at housing and exploring how Medicaid can build a better system of care and address social determinants for our Medicaid enrollees, a requirement of the federal government in seeking what's called a housing health-related social needs waiver, where we will build up our housing services, is that we invest in primary care. We needed a minimum of a 2% investment in primary care to meet the requirements of a health-related social needs waiver. That was built into HB 501, and this would fulfill both fee-for-service and ACO rates for that 2% rate increase. And Michael, that might be what you were thinking. Yep. And that was fully funded here. This did come through as a request that was a building block request for us. It was modified to only fund fee-for-service and not fund the ACOs. We built it back into HB 501 and we're able to fund it for all of our work. So there's a designated code list that will get about a 2.17% increase. And so we're also really excited about that. Now, what made all of this possible was actually item B on this list, which is a federal law around third-party liability that came out of the Consolidated Appropriations Act. The Consolidated Appropriations Act actually built in requirements where Medicaid is a secondary payer and we have a primary payer. When a prior authorization is on a service for a primary payer, the Consolidated Appropriations Act requires that when a prior auth is on a primary payer and the primary payer does not pay for that service, and the costs then are paid by the Medicaid agency, this law actually requires primary payer responsibility to not pass those costs on to Medicaid. And so this actually created a fiscal offset for us to be able to make HB 501 possible for justice, for some housing, which are largely expansion funds, do have some general funds, but also create this appropriation for the counties, which item C calls out that 4.127 900 million ongoing to the counties and the one time of 1.4. And it is because of the offset and this requirement that states put into their state statute this federal requirement around TPL. We will work out the details of TPL in administrative rule, but we can give you the details of that if you're interested in more information on that. Eric, would you like to go through the dollars and cents of this bill?
I can. It's kind of hard in this one because there's so much in there and they're kind of conglomerated numbers that are showing the net results of all those transactions. So as you can see, the red numbers look like reductions, which they are because they're all the, I guess, savings coming from that TPL change. So it dwarfs what would have been going out for the primary care rate increase. So they're very confusing. We put them in there because this is what the numbers are, but I don't know how relevant they are in general.
Yeah. Andrew, did that address your question? And Stephanie, I'm so sorry. I saw you come off your mic too.
You can jump in first, Andrew.
Thanks, Steph. I could if I could find the mute button. Yes, Janet. It did, and thank you very much. Thank you very much. Let me make sure I have that I heard the numbers right. The 4.7 is ongoing. Is that correct? So the only piece that we're hopefully going to have to fight over is the 1.2.
Yeah, correct. It's 4.1127. So okay. 4.127 ongoing. and 1.4 one time.
Great. Thank you very much for that. That helps a lot.
Yeah, you're welcome. You're welcome. And Stephanie?
Yeah, thanks for the thorough explanation of this, Bill. I just wanted to make sure I understand the Part B. So is that like, would an example be like somebody gets like a Medicaid beneficiary that's on Medicaid, gets in a car accident, and the other driver was at fault, and so their insurance should pay for their medical bills? Like, is that like, I'm just trying to understand like what, I don't know. I'm just trying to understand what that exactly is saying.
Yeah, let me use an example from, let's say, a pharmacy prior authorization. A medication is billed to a primary payer. That primary payer denies coverage of that medicine, either because the PA wasn't completed or the PA was denied for clinical reasons, not meeting clinical criteria. Then the full cost of that prescription is passed on to Medicaid, where then Medicaid processes the prescription. It might have a PA, might not. Regardless, Medicaid pays for the cost of that. The interpretation on this policy would say that the primary payer is required to carry the primary cost of that when they denied the PA, but Medicaid paid for it.
So it's only applicable to insurers who are dealing with a Medicaid as secondary covered beneficiary. I'm just curious how you're planning to implement that, because it would seem like the private insurers would still be denying the claims unless you notify them that the individual is Medicaid secondary, and just a few of those logistics to make sure it actually works as you're anticipating.
Yeah, we can bring some more details back on this. I think you're right. It is a little bit complex for us to like walk through, and we've begun discussions with the Department of Insurance even around how to not just educate the payers, but educate the providers who are often seeking the PA. They're the ones submitting the PA on behalf of a service, right? And so we recognize that while the responsibility for payment may be on the primary payer, that there's also some education that needs to be done with the providers who are issuing the PAs. Does that make sense? And then with regard to how this policy does get implemented, I think that what we know that we'd have to be working with the Office of Recovery Services on how they plan to implement and work through some of these policy changes. We can bring back the details of this as we work on the policy. Okay. We are working with some of our, some states have already applied this. And so we've looked at other state policies, and we're working with like our national association to really come to like kind of some standardized work that other states have maybe put in place already and help develop some things for us as well.
Jen, I just have one more question. This is Davis. Does the pharmacy assume any responsibility of that collection, or is that all going to be done behind the scenes?
It should be done behind the scenes. If you're saying, okay, so yeah, go ahead, Emma.
Jen, I was just going to say it's largely going to be done through cost avoidance, right? Mm-hmm. Because the system's going to be set up, or the systems are set up right now, if there's third-party insurance, to just deny payment. In most circumstances, there are a couple of exceptions. And then the issue is going to be, you know, Medicaid's going to deny the payment. The third-party insurer is going to deny the payment, unfortunately, to the provider. The provider is going to be upset. Eventually, it might end up in a fair hearing. I would hope in the meantime that either the division or ORS explains, you know, no, by law, it's the third party's responsibility. But some may just end up in fair hearings, and it's just going to be at the end of the day, well, sorry, third-party insurer is still responsible. The challenge will be, what if the third-party insurer still refuses to comply? And, you know, some of those may end up in district court, frankly, at the end of the day.
Thanks, Emma. That's helpful.
Yep. Thank you. Okay, we'll move past HB 501 and move into nursing care facility amendments. This allows a small change. Veteran nursing care facilities obtain a one-time approval for up to 5 certified Medicaid beds without the facility first proving bed capacity, insufficiency, or financial viability. So it allows some flexibility for state-owned veteran nursing care facility just to request some beds. It also limits the transfer or sale of beds in certain conditions. So it defines some limitations on that as well. SB 26, Behavioral Health Licensing Amendment. So this was a fairly large body of work that looked at addressing the behavioral health provider shortage in our state by creating a number of new licenses for individuals who are providing services in the behavioral health space. First, and we have these detailed here, it creates a license for a master addiction counselor and associate master addiction counselor. It creates a license for a behavioral health coach and certification for a behavioral health technician. It also expands the scope of practice for some behavioral health providers as well. Again, the purpose behind this bill is to really help provide a broader group of individuals who are licensed and certified and also have a broader scope of practice to support individuals seeking care for mental health needs and address our behavioral health provider shortage. SB 27, Behavioral Health System Amendments, also does some pretty important work from the behavioral health perspective. And I'm going to start at the bottom, is it creates a brand new commission called the Utah Behavioral Health Commission. This is outlined in detail in this bill, but really looks at the roles and responsibilities of this commission. It designates who these individuals are, and it also kind of outlines their scope of service, I should say. This Behavioral Health Commission will be led through substance use and mental health. And it also does another thing in this bill is that it moves the current USAVE group or Substance Use and Mental Health Advisory Committee into the Department of Health and Human Services underneath Substance Use and Mental Health as well. Third and last, it does repeal the Behavioral Health Working Group, which has been part of our HB 413 work group, which does meet this Friday. And so I know the work behind the Utah Behavioral Health Commission and identifying who those individuals might be, that work is started already. So if you know any candidates or individuals who might be great contributors to this committee, we would be happy. Those names can be sent through Sharon to Substance Use and Mental Health, who's arranging these, or you can send them to Brent Kelsey or others in that office. Okay, I'll move quickly through the next few. SB 32 Caregiver Compensation Amendments actually allows step parents to be recognized and compensated as caregivers for individuals who are under HCBS waivers. Parents are already given this benefit. This recognizes that step parents can be compensated as well. SB 166, Health Benefit Amendments, looks at individuals. This is a pharmacy policy that looks at formulary changes that happen in pharmacies and looks at individuals who've been on drugs for a long-term period of time, maintained on a certain prescription, on a certain drug for a condition. And it requires a notice to those individuals when a formulary changes so that the member is notified that, hey, I've been taking this for a very long time and your health plan has decided to change what they're covering on your formulary, and it alerts them to that change. This will be something that Medicaid is going to further build out. We do some of those alerts now, but we'll be broadly alerting with this update. Next is the Native American Health Amendments. This is a new service that has been crafted after a policy that is working its way through CMS from Arizona right now, but this opens traditional healing services for American Indian or Alaskan Native members. The provider has to be a designated tribal member, and the practices, so there will be a code that is opened that traditional healing practices can be billed to Medicaid. Eric, would you like to cover the funding on this?
Yeah, so the funding for the most part is put on and taken off for this year. There's just a little bit of administrative funding that's available. And I think it's, again, getting this program started. It just leaves us a little bit of money to get this program started in the first year. So the ongoing lines kind of represent better what the cost would be on an annual basis.
Thank you. This is an 1115 waiver, so that will go in queue with our 1115 waiver request. Thank you. All right. Last but not least of the bills we'd like to highlight is Medicaid reimbursement rate amendments. And Eric, I'm going to pass this entire one over to you so you can just describe the 2% and how that will be distributed for ABA services.
Certainly. So right now, accountable care organizations and behavioral health providers receive a 2% increase on an annual basis. What this piece of legislation does is it requires us to take those 2% increases, the ACO amount and the behavioral health amount, put it into a pool, and then take that total and divide it amongst the three groups: ACOs, behavioral health providers, and ABA services. So what we'll be doing, like I said, we'll be taking that money, putting it into a pool, and then allocating it out to those three different provider types. It is not going to happen July 1st of this year. It kind of has a delayed start, so it won't actually take effect. Well, the first, I guess, distribution like that will happen for the 2025, July 1st of 2025. So as you can see from the funding, all of it is in and out for this year.
Thank you, Eric. Hey, any questions on our presentation? Okay, thank you.
Okay, thank you. Lots of information there. We appreciate you putting that together and walking us through that. There's always a lot to learn, so thanks for the detail. Next, we have Michelle Smith. If you can get us
I do have
started.
a quick question. Michael,
Oh,
sorry.
no,
I
we
do have
don't
a
have
quick
time
question.
for your question. You missed the agenda item. We're clearly on to number 6, Stephanie. Go ahead, please.
Thank you. I was curious, Jen, if you all have a plan for navigating the potential of 463 being an interim item, and if it is, if you all have started to think through how to, like, what is your strategy for trying to make sure that that doesn't return in the future?
Yeah, thank you, Stephanie. That is something we will be engaging on internally. We are still gathering our post-session items and preparing for what we would like to even propose on interim. 463 navigation will be one of those items that we will be discussing in those upcoming meetings. Due to some other things that have happened, it's kind of delayed those discussions, which I'll cover later in the director's update with regard to the Change Healthcare outage. But it is on our agenda, and we're happy to share some of our thoughts on that when in future months.
Okay, thanks.
Okay, any other questions before we move on to agenda item number 6? Okay, Michelle, we are ready to hear from you now if you're ready to present.
Great. Hi, Michael. Thank you. So hopefully you guys can all see I'm presenting the monthly unwinding report. If I need to make
we can see it. Thank you.
Okay, perfect. Do I need to make it bigger, or do you think that's good?
Well, I think it's good, but I have my glasses on and I realize that not everyone has their readers available. So let's go with the assumption they can see it unless somebody tells us otherwise.
Okay, sounds great. Thanks, Michael. Okay, so as you guys can see, we've been showing this every month, just the activity that's occurring over the unwinding period. So as of the end of February, our total enrollment count for individuals in Medicaid was 355,226. You can see in the small turquoise, the individuals that we are still keeping open while the unwinding period wraps up is 32,647 individuals still left in that cohort. So if I scroll down, March is, we're really in our 13th month of unwinding. If you all recall, we really do have 14 months. So we went with, a couple months ago, I showed you all kind of the 3 different paths that CMS gave states a choice of. We chose the middle path, which was option B. And we started unwinding in March of 2023, initiating reviews at that time, and we will wrap up our unwinding period at the end of April of this year. For the end of February, we experienced 24,000 closures. I've kept on here our automation of ex parte, just in case you are all curious. Since we've implemented, on average, we are completing roughly around 15% of our ex parte renewals through automation. That we're seeing an increase each month on that, which is good. And we are still in discussions internally, along with DWS, to determine what our phase 2 of automation looks like to try and increase that number. Just scrolling down here, some of this is just kind of standard language that we've kept on here just for information. But just so you all know, in case you guys are following, each month we have been updating our online unwinding data dashboard, and that was refreshed on the 8th. If I have time, Michael, I would like to pull that up after I go through this report and just kind of go through some of the data that we have on there.
Yep,
And
then,
okay, perfect. And then this last, these last bullets, we talk about our CMS reports. I'll cover that a little bit more when I pull up the online data dashboard. For those of you that follow that, we do post those online, and we do have those in our graphs. So I'll go through those a little bit more when I pull that up. Also, with this next bullet here, CMS released additional guidance in October for states to start reporting outcomes for those pending reviews. When I say a pending review, these are individuals that, were pending, allowed more time because they initiated the review process and still needed to provide additional paperwork to complete that review process. So in our unwinding reports with CMS, we were initially reporting how many of those individuals were pending, but we were never following up to show the outcomes of those pending individuals. So those have been coming out, and we've been updating our online CMS reports with those outcomes. Yes, Stephanie.
Thanks, Michelle. I just want to make sure I understand this part. So this would be like someone who requests an extension because they didn't finish filling out their paperwork or they haven't finished verifications. And so they are pending. Is that correct? Instead of just like being closed at the 31st or the 30th, they are like given an extension. Is that like that's like those particular people?
Yeah, that's a great question, Steph. These individuals actually do not have to request that extension. So I'll give you an example. So if my review is due in April and I provide my review form or contact DWS or provide any sort of information that's showing an intent to complete that review before the end of April, DWS at that point would automatically keep that individual open and extend their benefits into the following month while they're determining ongoing eligibility for that individual. So the key that triggers that extension is any sort of intent from the member to complete that review process. Does that help?
I think so. So if they fill out the form and they are asked to send in pay stubs, so like just by them filling out the form, even if their pay stubs are not in by the end of the month, they're held open.
Yes, absolutely.
And what is the process like? So I guess if I understand correctly, I mean, this is important. And I hope that this like remains a policy that this is a frequent complaint, is that people start the process right and then they feel like they're closed when they're still trying to complete it. So did that start in November, or was it just the data part that started in November?
It was the data. So we've been implementing due process. Due process is basically the law around Medicaid. It's basically to do with proper notice and due process rights for individuals who receive Medicaid and CHIP. So if you are a Medicaid member, you're afforded due process rights, which means the Medicaid agency, in this case, with partnering with DWS, who administers the eligibility on our behalf, is obligated to determine first that you don't qualify for any other program. So if I'm showing an intent, I'm providing information to attempt to continue my eligibility, we are then obligated to continue your eligibility until we can make an actual decision on your case. So at the point that we can make that decision and give you proper notice, we have to continue coverage for you. Does that make sense?
Yeah, thank you. That's really helpful. So how are errors in that particular process determined, and how frequently are they? Because I appreciate that that is a right. I just know that there's just so many examples where that is not the case. And so I'd like to understand, like, if we know the errors. And then secondly, there are some states that have way more pending renewals than others. And so I've wondered, like, I don't know if you happen to know, like, or is it because they will hold people open even longer than just like one additional month, or if you understand why some states have higher numbers of pending. And then also just wanted to, it looks like the numbers here show that, yeah, so I guess just for those that are closed procedurally, do we know what's going on there? Because so they attempted a renewal and they didn't complete it. And so do we know anything more about that procedural breakdown? Like, anyway, are those questions clear?
Yeah, no, those questions are clear. Thanks for that, Stephanie. For your first question around due process errors, that's something that, Melissa Presley and myself can go back and look into, and that would be something we would have to get back to you on. I don't have that readily in front of me right now, so I apologize. For the pending, other states who have higher pending reviews, that's another one that I would have to go back because I haven't really monitored that or maybe understand their processes, or, it could be that they're behind on processing reviews. And so, like I said, until you are actually able to make a decision on an individual who is receiving Medicaid, you cannot close that individual. They have to remain open and receive coverage. So it could be that those states might be behind. I don't know, or they might have more Medicaid members. I'm not 100% sure. I'd have to go back and look into that and maybe ask a few states. And if you have some examples of states that you're referencing, that would help me too. For procedural terminations, that's an area, I know we've talked about that before in this meeting, and it's something that we are, heavily involved in looking at improvements and continually making improvements to try to, decrease those procedural terminations and determine, what's causing those, and doing a bunch of efforts. For example, the automation of ex parte, if we can complete more reviews, automatically up front without sending that review and that, possibility for an individual to fall through the gaps, by not providing that review form back or the information. That's our goal, right? To keep those eligible individuals on Medicaid. And then, in terms of other efforts, you're part of the notice work group. That's another effort area I know John has brought up and touched on in this meeting as well. And I don't know, Jen, Brian, or even Melissa with DWS, if you guys have more to add that I haven't added with that.
No, I think you covered it well, Michelle. I think we may feel a little bit restrained commenting on other states without that direct knowledge. We would have to be making some speculations, but it is a good observation you're making. Yeah.
Thank you. Yeah, thanks for the explanation, Michelle. I think it would be helpful both with like the due process errors, but just like the error process in general. I do feel like because especially over the unwinding, though, this was something that I know I have a lot of anecdotes prior to the unwinding, but during the unwinding, there's just been a number of individuals where in them reaching out for help and then tracking what's going on with their situation, the number of errors has been alarming to me. And I just am curious about what is like the flow chart of like, I would just be interested if maybe in a future MAC or it's just something, if nobody else is interested, I guess we can talk about later, or someone can email to me. I just want to understand more about like how are these errors defined and like how are they identified, and like what is the likelihood that there are errors being missed, and like and just understand more, or if it's just that the errors are very narrowly defined, therefore like a number of incidents that I'm familiar with maybe don't count as errors. And so I just think that would be something that would be helpful to understand with both the due process, but like all of the errors regarding eligibility.
Yeah, no, great question, Stephanie. You always have great questions, so thank you. I think this is definitely an area that, we monitor very closely and care a lot about, both us and DWS. And I know Melissa, hopefully you're still on the call. I don't know if you want to speak to this part because, I think we've mentioned before, DWS does have an internal auditing group, the performance review team, that continually looks at eligibility cases and identifies any trends and things like that. So I don't know, Melissa, if you want to speak more to that, if you're able to.
Yeah, thank you. A lot of our due process is automated, especially if someone turns in their review online. So a lot of that stuff, there's not even a worker intervention with some of that. So I think, Stephanie, it would be helpful to kind of know what you're seeing to kind of comment on errors and things like that. So there is some worker intervention on paper reviews and things of that sort, but a lot of what we've done is automate it so that it isn't error prone. So I think it'd be good to see, just to kind of hear what you're seeing so that we can speak a little bit more specific on that.
Yeah, thanks, Melissa. I can try to get some stuff gathered. I mean, so I know of an error that was automated. That's also concerning. I mean, automation does not remove errors. And so it's about how it's built, which is built by humans. And there's just like there are automatic closures that happen that were not supposed to happen, and they were automated. And so I just think that is anyway, but I can follow up with you if not, no one else. Yeah, if this is not, I can follow up with you outside of the meeting. That's better.
Okay. Sounds good. Thank you.
Thanks, Steph. Okay. All right, so I'll just continue on with our report. We've continued to provide case review status, and within each of these months, we do point out how many individuals were closed and then how many individuals were subsequently renewed. So up through this November date, we have complete numbers. Our next monthly report to CMS will be sent on April 8th. And then shortly after that, our dashboard will be updated. So just real quick, if I can switch over to this online dashboard, and hopefully you guys are all familiar with this and looking at it. I think we're pretty proud for putting this information out there and just making things transparent and for everyone to be able to follow what's happening with individuals. I'll highlight this last month of reports, and that's pretty small, so not sure if you guys can see that, but feel free to go online and pull this up yourselves as well. It's medicaid.utah.gov/unwinding. And if you scroll to the bottom of that page, it's the eligibility data dashboard. This last monthly report to CMS, you can see the percent of individuals renewed through ex parte was roughly around 18%. Members renewed by form, close to 17%. Members closed and determined ineligible, about 3%. And then members procedurally terminated, about 52%. And then percent of members renewed, reviews that are pended, roughly around 10%. If we go to this next tab, we're still tracking the movement for children moving from Medicaid to CHIP. So you see that's still occurring. This next tab under members just shows new members that are coming onto the program, and the definition for that is for anyone who has not been on Medicaid or CHIP within the last 3 months. So that's what we've defined as new members. And then these returning members are individuals who have had Medicaid in at least 1 month within the 3-month period. This next tab, other DWS eligibility activity, just gives the snapshot of everything that DWS has going on right now, which is quite a bit. As you guys can see, I think, Melissa, you might have mentioned this last time, DWS did receive a high volume of applications in the month of January. This was due to probably the highest account transfers from the federal marketplace. So they were dealing with a lot of workload January, February, and handled that very well. And then it shows some of their other application results and decisions and reviews and fair hearing requests. And you can see the fair hearing requests have increased. So that kind of shows at the bottom of that tab. This chart right here is just our presumptive eligibility. I know when this was originally explained, we kind of assumed we would see an increase once unwinding started, and we have. And then this last tab is around monthly call volume. So, you know, kind of it went down a bit from the month previous. Same with average wait times. It's currently, average wait time is 20 minutes. And then the abandonment rate dropped as well to 21%. So again, I encourage you guys to go on here and look. A lot of really good information, and just kind of helps explain a lot that is going on with unwinding. And if any of you have any questions, just as always, please feel free to reach out to me and Melissa. We're glad to help.
Great. Thank you for the report and going through this additional information. Would you be willing to just drop the link into the chat so that everybody who is just watching that presentation of data can have quick access to it if they want to follow up, see some additional diving into the details there. Okay, Stephanie, you have another question. Go ahead.
I know. Another is always the word. Sorry.
You're getting close to your quota, so just be careful.
I know, y'all. I think we're getting on less than a year left of this. I'm
No,
sure
no,
many people
no,
will be
I'm
glad
just
that I'm going to
joking.
be off soon.
Everybody has the same questions you do, so thank you for giving voice to them.
So there was some recommendations and suggestions that a few of us met with DWS and DHHS about prior to the legislative session, and there were some commitments that the agencies made related to enrollment. And we don't have to go through this now. If it's not a good time, I don't want to get in the way of the other agenda items, but I do think it's important that those commitments that were made are like put on the record for everybody, and also that like we make sure some of them related specifically to things that they would report to the MAC about, and just like other, you know, other things I think we would want to make sure that we get onto the, you know, get onto the public record here. So whether we do that today or like another time, I do think I want to make sure we don't let too much time go by before we have that conversation. And then secondly, in the original plan that was put together before Jeff left, there was a report that was going to be written, and I can't remember what the timeline was as far as when the report would be presented to all of us, but I wanted to make sure that that is still going to happen and what the process and timeline is for that. And then also, lastly, just wanted to check and see whether the dashboard will remain active after the unwinding ends, and if not, why? So hopefully the answer is yes, but if not, I'd like to know why it would not be.
Okay. Thank you, Stephanie, for your questions. I'll speak up on some of these. So first of all, we recognize there were a number of items that the MAC, as well as Representative Judkins, did present to both DWS and Medicaid teams. We've been working on these items. We've detailed what they are, timelines for them, and several of them are in progress right now. We're happy to bring these back as a collective list, as well as some of them have shorter timelines than others. And so I think some of them are going to be presented shortly to the MAC, maybe next month. I think we might have an April item. Regardless, we are working on these items. We're happy to report out on these and put them on the public record. The second piece is with regard to a report from Jeff. I'm wondering if you could describe what report, just for our, just so we know when we're thinking about which report you're referring to when you're requesting a report. And I think you mentioned Jeff. Jeff had said we would do it.
Yeah, it was on the, like, the website's changed, but it was one of the, Michelle, I don't know if you might know, but it was a part of the original, like, that proposal that y'all put together for the unwinding, and you presented it to the MAC, and in there, and it had like a timeline, and in there it had that there was going to be like a report out at the end of like lessons learned. Like it was just going to be like a I think there was like a where I can like go find exactly where it is on the website, but it was something that was like a formal, you all presented this.
Okay, we'll have to go back and review what that commitment was, and we'll certainly be happy to revisit that and walk through this. We are ourselves, of course, as we're finishing these unwinding activities, we've done many things in the context of unwinding, modified many of our systems, and definitely put multiple interventions in place and continue to move forward to do that work. So we're happy to look at that, look at the request, and reflect those activities moving forward as well, what we've learned and moving forward. So we'll bring that one back. With regard to the dashboard, we have discussed where we stand with regard to the dashboard as it exists today, and perhaps a different version of that dashboard. We don't have a final decision on that yet. That's another item we'll be bringing back, recognizing it is the end of unwinding here in the next few weeks and maybe month or so, and we will revisit that. So those are conversations we'll have in future meetings with you.
Okay, is that everything you wanted to get addressed, Stephanie?
I'll send the thing that you all committed to doing before over to you all.
Great. Okay, thank you for following through on that with us. Okay, we will now move on to item number 7 on the agenda, Director's Report. So back to you, Jen.
Thank you, Michael. I'll keep this semi-brief just for the sake of time. One item that was called out as the first item to touch on when in the director's report today was our Change Healthcare outage. I do want to give adequate time for this because in the context of the last meeting that we had a month ago and now today, there's been so much activity that's occurred in the Change Healthcare space, the impact to the Medicaid program, and then works that we have put in place. So I just want to walk through that. So on February 21st, we were made aware that morning our team went to log into the Change Healthcare system, could not get into the system. At that point, we thought it was a system outage or an access issue with our VPN system that we use. Later in the day, of course, we became aware of a more greater incident. Change Healthcare did bring down its systems, and we were working sort of on a day-to-day basis early on. Moving forward, we did stand up a number of programs and meetings, programs, services, and operations to address what ultimately became a 3-week pharmacy outage of the Change Healthcare pharmacy system. So specifically, and we know that the Change Healthcare cybersecurity incident it goes far beyond Medicaid pharmacy, but I'm going to start and first talk about Medicaid pharmacy. So Medicaid pharmacy processes its claims on the Change Healthcare system for fee-for-service processed claims. We do have 4 pharmacy plans within our ACOs that are doing those physical health prescriptions for ACO enrollees. So this specific impact is looking at fee-for-service Medicaid members who get all their prescriptions through fee-for-service, and then the carve-outs. Our carve-out medications that run through fee-for-service pharmacy are psychotropic medications, so antidepressants, mood stabilizers, anti-epileptics, benzodiazepines, and medications like that, high-cost medications run through the system. When the system went down, there was no way for pharmacies to bill Medicaid for these services. And it goes beyond this because of Change Healthcare also owning a switch vendor, which does part of the transmission of a pharmacy claim. When a pharmacy leaves, a claim leaves a pharmacy, like a Walgreens, for example, and it gets billed to Change Healthcare, there's actually an intermediary called a switch. And that switch vendor, it transmits from the pharmacy through the switch vendor over to, in our case, Change Healthcare that serves as our pharmacy benefit manager. Both pieces of that Change Healthcare system were affected by this outage. And therefore, pharmacies that did not even use the Change Healthcare pharmacy benefit manager were also affected by this switch vendor. So we saw system outages statewide from the switch impact, as well as the impact to pharmacy, Medicaid pharmacy claims processing. We put out multiple media alerts for members as well as providers. We also put forth an effort our first weekend to call 20,000 members and alert them that medications that they would be expecting refills on, that they might encounter challenges getting those medications. And we walked through what this meant. With this, we worked with our pharmacy providers during this outage because they could not bill Change Healthcare and get a paid claim, which is an essential piece of pharmacy operations, is that literally instantaneously when they push send, it should quickly run from that pharmacy to the switch vendor, over to the PBM, and then back to the pharmacy, and give messaging like early refill, prior authorization, or paid. And then it would print out the label. None of that was working for 3 weeks. We stood up workarounds. Our workarounds were effective, and I think mitigating many disruptions in services that Medicaid members were to experience. We provided assurances to our pharmacies that we're providing these medications, that we would make them whole. We asked them to provide a 30-day supply of medication to the member at no cost. We also waived cost sharing requirements during this time frame. During this time, our ACO partners also stood up workaround override processes. So pharmacies had another avenue to actually call the ACO and bill the claim to the ACO and get an override on that and actually get a paid claim. So they could do that. Recognizing this could be a financial impact to our pharmacy providers, we stood up an interim payment solution so that we could provide payments to providers during this outage. After 3 weeks of downtime, dozens of meetings, and lots of coordination of care to make sure members got the medications that they needed, our pharmacy system did come back online last Wednesday. What specifically happened at this time is that Change Healthcare took our data that was in our Utah pharmacy system. It had been cleaned and it was the Utah design of data, but they put it into a new environment on the Optum side. At this, the pharmacy claims could process, the pharmacies could get a paid claim. However, it was very limited functionality. So we continued to provide significant overrides on the pharmacy claims processing side. Specifically, we are not requiring today our team, while they have access to view claims, we do not have the ability to run prior authorizations. We also want to honor all the additional work that pharmacies have had to do during this outage period, and to create and really promote member access to their medications and facilitate pharmacy claims payment. As we've just now been back online for 1 week, we have lifted early refill requirements, lifted quantity limit edits, and many other types of controls in the system. And we've, of course, created significant notices or significant outreach to providers to let them know the rules of what was going on. In that 1 week since our pharmacy system has come back online, we've processed 170,000 claims and put out this past week $6.8 million in normal provider payments to pharmacies for the work that they have done over this time. That volume of work that was submitted in the 1 week does actually represent about a month of our usual activity on the fee-for-service side. One of the things that we have committed to do during this outage was we know that pharmacy providers took on an extraordinary amount of work, additional work to service Medicaid members. They filled a 3-day supply, a 5-day supply, and then a 30-day supply. They did workaround methods to do this. They had to do bookkeeping and additional staffing needs. So what we've done is we have paid additional dispensing fees to pharmacies for every prescription that was filled during this 3-week outage. We paid a dispensing fee for every prescription claim that was processed during this time. We've also lifted almost all editing during that time, so that pharmacies could get paid for the money that they for the medications that were dispensed. This is a long road ahead of us. We have significant interruptions still. We can't do prior authorizations. We can't manage our restricted accounts. We have no reporting in our system right now. We are simply processing claims, looking at member eligibility, processing claims, and then paying providers for that work. We also know that beyond pharmacy, there's drug rebates that our state gets and relies on about $72 million per quarter in pharmacy drug rebates, where all the medications that run through our system, our manufacturers are invoiced for those medications, and then we do get rebates to the tune of about $60 to $70 million per quarter. When the Change Healthcare outage occurred, our pharmacy rebates for the fourth quarter of last calendar year had not been sent to manufacturers. So therefore, we have not been able to get any rebate amount. Those monies are not being collected as invoices have not been sent. We also have an inability to generate new rebate dollars or put in those claims at this point in our system, and are looking at the impact of this quarter and being able to rebate. A couple important pieces in our Medicaid program to ensure that we are getting federal payments for some of these and a federal match on many of these services that we've been put in place. Number one, we have submitted a SPA, our state plan amendment, to CMS yesterday to allow a waiving of member copay requirements from the beginning of the outage and through up until we establish full system functionality again. And so we've submitted a request to that. We are also drafting a request for interim payments so that we have federal match on all interim payments that have been issued since the outage. CMS has stood up a nice document that does outline flexibilities for state Medicaid programs to seek additional flexibilities during this time. We're also sensitive to auditing during this period, and we are building operational procedures to ensure that auditing both that address access to care, but also appropriate fraud, waste, and abuse controls are captured during this time frame are in place as well. So, Michael, I've gone on and on. 10 minutes. It's a lot of work just simply for pharmacy. We know this and recognize as we've stood up statewide calls with the Department of Insurance, stakeholders that are primary people here in that go beyond pharmacy, that the Change Healthcare outage has affected Medicaid providers in meaningful ways, even outside of pharmacy. One of the reasons we are requesting interim payment authority from CMS, even beyond pharmacy, is knowing that this may be a long journey. We recognize that our providers are impacted in ways that impact electronic health records, data screening, EMRs, many different things, where Change Healthcare does different clearinghouse work. As a result, we believe that with a continued outage, Medicaid providers may be experiencing financial shortfalls. And where we can, we are working with our partners in the state, but also preparing ourselves to provide interim payments to Medicaid providers outside of pharmacy throughout the next weeks and months as these systems come back online. So with that, I think I will stop. But it has been coming out of session. We thought, coming out of session, and then a week before session ended, or I guess a couple weeks, but about a week before session ended, this hit us. I have to just thank our team and many of you on this call for working collectively with us to keep our pharmacies intact and supported, but also our members getting them the medication they've needed during this time.
Great, thank you. Yes, a lot of work, lots of impact there for sure. If there were providers or people who know providers who are experiencing some shortfall, you'd mentioned the option of getting some relief. I think you put in your MIB that there was a process there for people to approach the department, but do you have any general guidance you'd like to just share for specifics on if somebody wants to reach out to the department?
Yeah, that's great. Medicaid.utah.gov. Right on that, you'll see a big bright banner that does have that notice around pharmacies. It connects you to all of our notifications that we've put out with our FAQs to members as well as providers. And it does give you a link to an interim payment portal. It looks like we did with Prism. So there's a specific amount the provider can request, and then that money will flow later that week. But Medicaid.utah.gov.
Great. Okay, thank you for your report there. Okay, final agenda item we have. Okay, looks like Jennifer Marchant has a question. Jennifer, go ahead.
Yes, can you hear me?
Yes, but it's a little faint, so maybe just project a little bit more.
Oh, okay. Just before we moved on, I wanted to say to Jennifer Strohecker that I saw her on the news a few times and she did a wonderful job. So I can't imagine how stressful this has been the past few weeks, but just for what it's worth, when you were on the news, you did wonderfully. So thank you.
Thank you.
Great, thank you. All right, and then just comment in the chat from Beth there. Okay, any other comments or questions before we move on? Thank you from Stephanie, very nice. Okay, thank you for your report there. Okay, final agenda item we have. Okay, looks like Jennifer Marchant has a question. Jennifer, go ahead.
Oh,
Yes, but it's a little faint, so maybe just project a little bit more. Okay, then our final item on the agenda is just any committee member updates. If you have any comments, things you're experiencing as you're interacting with groups that you interact with or represent that you would like to bring up or plan to have us add to a subsequent MAC meeting agenda. Stephanie.
Sometimes I wait a second to see if anyone else jumps in. So I don't know, like, if there's a way to like assess how often this is happening, but I am curious, and so I'll just see if anybody else on the call has heard of this as well. But um, when members are billed significant amounts for a hospital bill, um, it's just really hard to figure out why exactly members would be billed whenever they like Medicaid should be paying for it, right? Or their plan should be paying for it. And I don't know if it is something that it's something that I heard about before COVID and then not during COVID and then heard about it again since the unwinding started. So I don't know if it's because plans are like not sure if somebody is like eligible. I don't know. I don't know if it has to do with like there was kind of continuous eligibility kind of, and now there isn't. I don't know. It just seems to be that just seems to be what the timeline is as far as what I've understood. But I'm just curious if anybody else has heard about patients being essentially like balance billed. And I know it's against the law and I know that like it doesn't happen, but it does happen. And I do have like, I will send some, I do want to show whoever is the right person. Like I have like screenshots of it. So I do know it's happening, but I just wanted to see if that's something that others have heard about as well. And if anybody from this industry side can comment on why it might be happening if from what they understand related to like the plans or the hospitals. It always is the hospitals. From what I've heard about it happening with behavioral health too, but it's almost always the hospitals. And so I just wanted to throw it out there.
Okay, Jen, do you have a comment? And then I will comment as the hospital representative.
Yeah, go ahead, Michael. And I'll just say we've had a couple reports on this that we've worked through, Stephanie. As we hear about these things, we take the individual cases, we look at them and work on them with the members. But go ahead. I know Tracy Barkley's worked on some of these items. Go ahead, Michael, with your comments.
Yeah, I mean, any situation could be different and unique on its own. So recognizing that could happen. But I think there have been a number of points of question over the past year with the implementation of the PRISM system and whether someone is actually enrolled in Medicaid. And there have been a number of eligibility issues in terms of people showing as being eligible for Medicaid and should be enrolled in a health plan. And then that retroactive eligibility the eligibility has been taken away retroactive to previous periods of time. And sometimes there's some confusion as to whether the person actually is enrolled in Medicaid. But of course, the process should be, if we accurately have the person determined eligible and enrolled in a specific plan, whether it's a managed care plan or just regular fee for service, given their timeline, then the Medicaid payment rate should suffice and there shouldn't be any balance billing to the patient unless it is for the copayment that's required for a specific service. So I think to get into any more specifics than that, we would probably want to look at specific cases. Hopefully it's somewhat related to some of those known issues rather than systematic bad actors or people just trying to balance bill, because there's a lot of noise in the system systematically in terms of who's supposed to pay, sometimes paying when the person's not eligible.
Okay, that's helpful. I mean, if I may make one suggestion that if you would like to just take back to your to the hospital association, I think especially when Medicaid beneficiaries are sent to collections, I mean, that is especially from nonprofit institutions, I think that is a huge, that's going to really cause a lot of mistrust, right, in the healthcare system. And I think that that is going to cause negative impacts for patients, for plans, for hospitals, et cetera. And I think if there is a way that the hospitals can together decide that they will not send Medicaid beneficiaries to collections ever, I think that that would just be like a positive thing to do. But like I can try to find, like, get the specifics organized and send an email to some of you about it. But I do think that this is like, it's like not the only time I don't know, I've heard about it in enough examples that it makes me a little bit nervous about like whether there's been some, I just don't understand how that can't get resolved, right? I just, being sent to collections when you're a Medicaid beneficiary for something that should be covered and it's not a copay. It's just like, I'm not exactly sure where there, and it's really hard, it's hard, it's unclear on the bill, it's very hard to figure out exactly what's going on. And I think it would be really helpful if the hospitals could try to make sure that is just a policy that they will not send Medicaid beneficiaries to collections.
Yes, and I think I'll definitely bring this up in our monthly meeting that we have next Tuesday. But again, just in terms of, I don't think you're going to find anybody who thinks in the provider community they're balance billing a Medicaid patient. I think there's probably confusion over whether that person was enrolled in Medicaid for the specific dates of service. And again, there could be a number of reasons as to why that would be the case, but definitely appreciate the feedback. And I think the department also has been working with you, looking at some of these things, and maybe we can look at some specific examples and see if there are specific cases that could be prevented with just a little more coordination there. Okay, Andrew has his hand raised. Go ahead.
Jen, based on what Michael just walking through a couple of the possibilities to maybe explain this, I'm wondering if since I've had the experience for the last couple of months of getting bounced back and forth between the ACO and the fee-for-service system because of issues with PRISM, I'm wondering if any of that could be potentially at play here as well.
Yeah, I mean, I certainly believe, Andrew, we have to look at these as we learn about them and investigate what happened with that case specifically. Certainly, it could be the numerous changes that have happened with a person's enrollment in PRISM as it may have moved people, right? We have to look at the cases as they come in to really understand what the source is. Go ahead, Emma, I'm sorry, but
No, I agree with you, Jen. I mean, everyone is so fact specific, right? Each situation. And the other thing I would say is just encourage people to let us know, whether to let the state know or if they believe they're enrolled in an ACO, to let the ACO know, because it has been a challenging year and none of us want to see anybody balance billed. And usually when we reach out to providers and explain to them the situation and clarify the enrollment, they're pretty good about it. Where there are some bad actors, those particular providers are actually referred to the Office of Inspector General, and they get a nice little call from the Office of Inspector General to remind them that they cannot be balance billing members. So I would just say it has been challenging, and just encourage you to let somebody know that that's happening so that we can try to address it.
Good feedback. Thank you, Emma. Jen, go ahead.
Yeah, just one thing too regarding like a member's rights and recognizing that we also can do education with regard to really alerting the members and helping them understand, and working with our ACOs too, to really do some education to give members confidence that when they do get something like this, make them aware of what their rights are and what they have, what channels they can access to ask the right questions, right? Stephanie, I think that's some of the challenges. People might not even like be aware and be, so I'll just say we can do our work as well as we recognize this is an issue we can revisit, and making sure members have an awareness of their rights.
Good comment. Brian, did you want to say something too, or you took your hand down?
No, I think Jen covered it well. I think yeah, member guide is one thing specifically to that end, but maybe it's other things too help in that effort. Thanks.
Great. Yeah, definitely good options for us to look at how we can better inform people of how to approach solving the problem, and we'll try and look on the provider side and see what better communications or systems fixes can be contemplated there. And then we'll bring it up as a follow-up item next month and have a little broader discussion on other action plan items. Okay, well, we have magically made it to the end of 2 hours. Thank you for all of the presentations that have been made today, and comments, questions, and feedback. A lot of good discussion. So we will take a motion to adjourn and then look forward to meeting everybody again next month in April.
This is Kim. I'll do a motion to adjourn.
Okay, thank you. All in favor, silently remain in, okay, no opposition. We'll consider that unanimous and be adjourned until next month. Thank you.